Okay, got it. All right, so okay, this is the loop of Henle. Okay, this would be the proximal convoluted tubule. And this would be the distal convoluted tubule. Okay, and inside you've got those knot of capillaries. Which is the glomerulus. Okay, so the proximal convoluted tubule gets its name because it is closer to Bowman's capsule and the glomerulus, and the distal is because it's farther away from. Okay, one of the points of all this is to increase surface area, okay, for filtration. Okay, so as fluid is coming in to the inside the kidney, right? You have fluid coming in, and it's going to travel through all this. Just drawing the direction of fluid here, so it's going to come down, go up, go this way, okay, and then eventually into the collecting duct. And then eventually into the urinary bladder. Okay, and then eventually you're going to micturate, which is a fancy word for peeing or going to the bathroom. Okay, void, micturate, or peeing. Okay, the whole point of, or one of the whole points of micturation is to get rid of waste. Okay, and we'll talk about that waste in just a minute. Okay, another way of looking at the kidneys. Okay, another way of looking at the kidneys is it keeps the good stuff and gets rid of the bad. Okay, very simply put, it's a big filter, keeps the good stuff, gets rid of the bad stuff. Okay, so this concept will help just about any kidney disorder make sense. Okay. So some of the waste is going to be ammonia. Okay, toxins, drugs, electrolytes. This is my shorthand for electrolytes and urea. Okay, not an exhaustive list, but and hydrogens. Okay. So your body will get rid of this, and you don't want these things to be recirculated into your body. Okay. You start to recirculate these things in your body, and you're going to start to create some problems. All right. Another one we should add is carbonic acid. Okay. All right, carbonic acid, drugs, toxins, electrolytes, urea, ammonia, hydrogens. Some of the things that our body will eliminate. Okay, another important thing to know is pH. Okay, so 6.9 to about 7.8. Different authors will say different things. Okay, I've seen 6.5 to 7.5. But here's the thing. When you start getting closer to 0, this is not good, which is more acidic. And when you start getting more alkaline, also known as basic, okay, this is also not good. And that range would be 14. Okay, so 0 to 14 is your pH scale range, and you want to be relatively neutral. Okay, it also depends on the body tissue that is going to be affected with pH. Okay, so in other words, different parts of your body are more sensitive to pH than others. Okay, a good example would be cerebrospinal fluid. Okay, so your nervous system is going to be a lot more sensitive to pH changes. And once you start messing with that, then you start risking significant problems, including coma or death. Okay. So metabolic acidosis, okay, is too much acid, okay, or increased acidity in the body. All right, and this will be due to a decrease in bicarbonates. Okay, so HCO3 is a bicarbonate. Okay, so you have decreased bicarbonates. Okay, now a quick note on bicarbonates. Okay, if you have a decrease in the bicarbonates, it's usually because of an increase in acids. Okay, so a decrease in bicarbonates is usually because an increase in acids. So too many acids are coming in, not enough bicarbonates to help buffer the system. Okay, so a buffer is anything that helps regulate the acidity. Okay, so our kidneys do that. Our breathing does that. Just for some easy examples. Okay, so other things it could be due to kidney dysfunction. Okay, so due to kidney dysfunction, of course, there's a million things that can happen to the kidney to create dysfunction. So this covers quite a wide range of disorders. Okay, a decrease in pancreas function. Okay, a decrease in pancreas function. Okay, the pancreas does release its own form of bicarbonates. Okay, so if pancreas is messed up, then one of the things is a decrease in bicarbonates. All right, and this one will also show signs and symptoms of GI dysfunction, since the pancreas is involved in a ton of gastrointestinal function and digestion. Okay, others can be an increase in ketones and an increase in lactic acid. And then another one to watch out for is prolonged diarrhea. Okay. Losing too much fluid, too many things passing through the body too quickly. Okay, that can create an acidic environment. Okay, so how will the patient present? Okay, so signs and symptoms. How will the patient present? Okay, so we're going to list a bunch of stuff here. They can have things like a headache, okay, abdominal pain, they can have increased respiration. Okay, if you have too much acid in your body, your chemoreceptors will detect that and force your respiratory system to try to breathe more to get it out. Okay, it's kind of the body's knee-jerk reaction to try to help. Okay, so increased respiration. The fancy word for that would be hyperventilation. Okay, central nervous system. Okay, remember the nervous system. So the central nervous system is your brain and spinal cord. Okay, all the other nerves outside of that is a peripheral nervous system. So your brain and spinal cord, or the CNS, if that gets hurt, you'll see things like coma, confusion. Okay, they'll be lethargic. Another word for confusion is stupor. Okay, stupor is a fancy word for like mental confusion or decreased mental function. Okay, if the central nervous system is, or if the patient is showing signs of CNS issues, okay, be thinking CSF acidity. So cerebrospinal fluid acidity. Okay, treatments. You can give bicarbonates. Okay, you can give the patient bicarbonates. One of them will likely be which is sodium bicarbonate or baking soda. Commonly known as baking soda. Okay, in fancier stages, you can do the hemodialysis. Okay, and then diet and lifestyle changes. Okay, so you want to coach them on diet and lifestyle changes. All right, next one is metabolic alkalosis. Okay, so this one is too much bicarbonates. Okay, too many bicarbonates and not enough acids. Okay, so you're approaching more of the 14 range on the pH scale. All right, one reason for this, and this is a thing, even though you wouldn't think so, is a person consuming, let's see, increased intake of baking soda. Okay. So some people, well, I should rephrase that. A lot of people go online to Dr. Google and type in symptoms and, you know, all these things, and they type in keywords, and then they get advice, and they get help, and they get diagnosis stuff and all that from internet search. Okay, everybody does it. So that's a good and a bad thing. Okay, the good thing is, in general, you know, your own personal online research can educate you. You can learn. There is good information out there, but at the same time, people can start doing a protocol and not really know what they're doing, and end up getting hurt. Okay, so just don't forget well, actually, they usually tell you, yeah, I went online and I looked for this, I looked for that. Okay. Just validate and be like, okay, yeah, that's great. You did that, but here's, how we're going to handle this. Okay. You have to redirect them into a better direction. Okay. Another reason is a decrease in stomach acid. Because of emesis, which is vomiting, or we should say too much vomiting. Okay. Hospital caused, so iatrogenic, and that would be gastric suction. Okay. And the reason why the hospital would have had to do a gastric suction is because of consumption of poisons. Okay, consumption of poisons. Okay, some other causes to look out for metabolic alkalosis is hypokalemia. Let me do that over again. Hypokalemia. Okay. Don't forget the K there is potassium. Okay, another one would be blood transfusions. Okay. All right, signs and symptoms. Shallow breathing. Because of increased carbonic acid. Okay, so carbonic acid is a byproduct that's unique to the lungs. Okay, so they'll have an increase in carbonic acid because that's what they're trying to do, right? So if you do shallow breathing, you're trying to change this by creating more carbonic acids. Hypotension. Okay. Muscle weakness due to the decrease in potassium. Okay. Once this happens, you can also get this thing called tetany. Okay. Which the patient's hands and feet will spasm. Okay. They contract funny, they spasm. And also a decrease in potassium can cause tingling, usually in the fingers and toes. Okay, that's usually where it starts. And it can be the whole foot, can be the hand, and eventually the entire arm, the entire leg, and then the lips. Okay, so be looking for tingling and tetany. Okay, likely an indication of alkalosis and decrease in potassium. All right, next one is respiratory acidosis. I didn't mean to do that. Hold on. Okay. So respiratory acidosis is an increase in carbonic acid. Okay. And then keep in mind, carbonic acid is excreted by the lungs. Okay. This is usually this is another way of saying CO2. Okay, so carbonic acid is excreted by the lungs in the form of carbon dioxide. Okay, so typically you're going to have an increase in the PaCO2. Okay, that means partial pressure of carbonic acid. Okay. So if you have an increase in your carbonic acid, you're likely going to have a decrease in bicarbonates. Okay. And then there's two forms of this. You have acute and chronic. Okay, so acute it's abrupt, so it's right now. Okay, so abrupt respiratory failure. And people that, you're likely to see this coming in an ambulance or something like that, right? Usually emergency cases. It has to do with drug overdose, trauma, other things like neuromuscular disease, and the neuromuscular disease decreases muscle function, and muscles are a big part of breathing, right? Diaphragm, intercostals. Okay. And then chronic, these are going to be your COPD type people. Okay. And any other chronic respiratory illness. Okay. And then usually in this family, it's, usual suspects of like smoking, obesity, diabetes, kidney dysfunction, fluid retention in the lungs, stuff like that, right? So those are your chronic cases. Okay, so if we have a respiratory acidosis, we have to have a respiratory alkalosis. Okay, so this would be a decrease in CO2, right? Fancier way of saying that is the decrease in carbonic acid. Okay, and you're becoming too alkaline, which means you're getting closer to 14. Okay, so you may have a score of 8 point something, 9 point something, whatever. Closer you get to 14, the worse it is. Okay, so this could be caused by hyperventilation. Okay, and lots of things can cause hyperventilation, such as increased pain, increase in anxiety, infection. Okay, usually with gram negative species. Okay, drug overdose. Okay, so with hyperventilation, you are breathing too much, and by doing that, you're changing, right, the acids and the bases, and you actually don't have enough CO2. It's kind of weird to say. You wouldn't think your body would want CO2. Okay. So you're spitting out too many CO2s, and that's starting to throw off the ratios. All right, a sign and symptom. Hypoxemia. a numbness and tingling, and usually like body pain. Okay, so it's just an overall just pain. Okay, you want to put yourself in a complete alkaline environment. It does hurt. They just ache. So those are some signs and symptoms. Okay, so I'm going to do a very quick renal function review and reminder. Okay, so because there are some things that you should know. Hopefully this is a review from ANP2 when you did renal stuff. Okay, so let's just do a quick renal review of function. Okay, so earlier we mentioned the kidney's job is to keep the good stuff and get rid of the bad stuff. Okay, and we drew out the nephron earlier. Okay, and then we did the glomerulus and the proximal convoluted tubules and all that stuff. Okay, the whole point of that, the whole point of the nephron thing is to help with filtration. Okay, so specifically what we want to look at is this thing called the GFR. Okay, the glomerular filtration rate. So earlier we had that glomerulus with the knot of capillaries, right loop of Henle, distal convoluted tubule and all that. And the way to try to look at this is, okay, fluid is constantly coming in, traveling through, okay, and some things are also recycled, right, to go back to the body. So the kidneys and the nephrons are going to, through the arteries and the veins, the arterial system and the venous system, as fluid is getting pushed into the kidneys, you will lose some of it in urine, and you're going to keep a lot of it through just being recycled. Okay, it gets reabsorbed. All right. This is your filtration rate. How fast is this fluid coming into the kidney, and more specifically into the nephrons, and then more specifically into the glomerulus? So we call that the glomerular filtration rate. Okay, and you can do a lab on this to figure out where the person is at. Okay, so some hemodynamics that you would expect. If you have an increase in blood pressure, you should expect an increase in the GFR. So if fluid is being pushed in faster because the pump is working harder, well, sure, the filtration rate should go up. If the person has a drop in blood pressure, then the GFR should go down. Okay, so the pump isn't working as hard, so the rate of fluid moving isn't as fast, so the filtration rate will go down. Okay, so within normal limits, right, homeostasis reasons, that's fine. Our blood pressure is constantly changing and the heart rate is constantly changing. Depends on if you're exercising and you're resting and whatever, right? There's all sorts of stuff. Okay. The other thing to consider is your hormones. Okay, so hormones are a big part of kidney function and filtration rate and blood volume and all that stuff. Okay, so blood volume is huge. Okay, blood volume. Okay, kidneys are responsible for helping you with blood volume. Okay, and some of the hormones that help with this, antidiuretic hormone, aldosterone, okay, ADH and vasopressin. Come back to that in a second. Okay, and then aldosterone and angiotensin 2. Okay, so ADH, it's funny because it's the same hormone, but they have two different names depending on where it goes, right? So the ADH one goes to the kidneys. To keep fluid. And vasopressin goes to your blood vessels. And it does what the word says. It presses on the vaso. So it takes a blood vessel that was that big and then basically presses it down. And now it's that big. Okay. So that's vasopressin. Okay. Now, if you just give it an extra thought, what happens to the pump if it has to push fluid through a tiny tube? Okay, it's a lot of work to push fluid through a tiny tube, so this would increase the blood pressure. So by keeping fluid, which increases blood volume, and squeezing the tube tighter, okay, all of this increases blood pressure. Okay, and the kidneys have to release the renin, okay, which is an enzyme in order to help all this stuff, okay, to start that whole aldosterone angiotensin mechanism. Okay, diuretics diuretics inhibit water reabsorption. Okay, so earlier we said the kidneys help you get rid of fluid, right? So you pee that out, but it can also recycle it, so you can keep fluid. But a diuretic is going to make you lose fluid more rapidly. Okay, so we can do this to ourselves, meaning we can consume certain drinks and fluids and stuff that are a diuretic, or you can do it medically. So sometimes hospitals have to hit people really hard with some diuretics to flush out the kidneys. Okay. All right, kidneys and urine analysis. Okay, a UA. All right. So you want to look for things like the color of urine. It should be kind of a light yellowish color. So if it's red or a very dark red amber color, not good. Okay, something's going on. You want to look for pH. Okay, to keep it simple, 6.5 to 7.5 is a good range to be in. Okay, specific gravity. Specific gravity. This can help with assessing dehydration. Okay, you're going to look for red blood cells, white blood cells, protein. Okay, you shouldn't find protein in the urine. Glucose, ketones. Nitrites, casts, and crystals. Okay. All right. So I carry some dipsticks in my office. Okay. So this is the easy version. You have a dipstick and they have different color-coded pads on them. And the person basically pees in a cup. Okay. You take the dipstick and you dip it in. There's different types of cups or tubes. You can actually have it transferred into a nice big tube so the dipstick goes in easier. But you want to get all of these different reactive pads in the urine, and then you give it usually 60 seconds to acclimate. Okay. And then you put the strip against a like a legend, right? So there's a meter or a legend or a color-coded graph, and you just look for the color, okay? So let's say this one here was white, and then it turned red. Okay, that's obviously not good. Something is going on. Okay, so those are the kind of things that happen, is the different colors on the dipstick. You know, they come right out of the tube with a certain color, and after you dip it into the urine, they can change color. And you're looking for that on your graph, and you mark what you find, okay? So were proteins present? Did it pick up on white blood cells? Is there presence of blood? How much glucose is present? Is the person spilling ketones into the urine? That would be ketoacidosis stuff. Okay. You can also look for bacteria. Okay, now once you get into this family, this is going to be more of a visual exam. Okay, usually under a microscope. And then once they find these things, then they can figure out what species or whatever that you're dealing with. Okay, so these are just things in the UA. They're routine, they're very good, very easy to obtain, and reveals lots of good information. And depending on what the positive finding is, depends on the treatment. Okay, so for example, if all these were positive, let's say, and white blood cells were present, now you're dealing with infection, and they would likely need to be on antibiotics. If the specific gravity only was messed up, then they're just dehydrated, and you got to encourage them to drink good fluids. All right. And so it just depends on what is positive on the test, if any, right? So some people's come back normal. Okay. Urea is the end product of protein metabolism. Okay. And it is excreted by the kidneys. Okay. I better not do that. Might misinterpret that for potassium. Okay. Excreted by the kidneys. Anybody want to take a guess at the lab that you do?
Bun?
Yes. Blood, urea, nitrogen. Whoops, not that. Okay, another one is creatinine. Okay, this is the end product of muscle metabolism. Okay, this MM there is muscle, shorthand for muscle. Okay, so now that we know that, let's get into some, and we only got 20 more minutes, you guys hang in there. Okay, we're going to get into some renal disorders or some other renal disorders. Okay, so for starters, the patient's going to come in with pain. That's likely what's going to bring them in to see you. Okay, with respect to the kidney, there's some fairly classic presentations kidney pain has. Okay, and that would be flank pain or pain around the lumbar or thoracic lumbar junction. Okay, kind of like I would say, they'll probably point to T10 to L2 area. So thoracic number 10 down to L2. They may even go as low as T10 to L5. Okay, so thoracic lumbar area. And then pain can radiate to the groin. Okay, so kind of radiate down to that inguinal area or the groin area. So they'll point to the actual kidney area, the flank, the lumbar, thoracic lumbar, down to the groin. So any of those can be a sign and symptom that the kidney, something's going on with the kidney. Okay. I happen to see this quite a bit because, you know, I do a lot of musculoskeletal work on people. So they come in and they're like, my back, my flank, my ribs, I pulled a muscle in my groin, Okay, and I can see that, right? They're like, I just think I have, the patient doesn't really say it this way, but what they're saying is, I have musculoskeletal pain. I want you to fix me. So I go, okay, well, let's do an exam, right? So start with your history and then start with your appropriate exam. Okay, and what I mean is, if a person comes in with low back pain, I don't think you have to do an exam on their wrists. Okay, like go to the area of chief complaint and then go to the associated areas with the chief complaint. So they're complaining of low back pain and flank pain and that kind of thing. And I start doing the musculoskeletal exams and orthopedic tests and stuff like that. And I'm like, there's nothing there. Like everything's fine. Like I don't feel anything wrong with the musculoskeletal system. Oh, let's look at kidney. Okay. Do you have a history of kidney infections? Yes. Okay. And you start going down that route, and all of a sudden, the pendulum swung to the other side. So now you're moving away from musculoskeletal issues and you're moving toward kidney. All right. So there's some tests you can do in office right away. Okay, so UA is one of them. So I have them pee in a cup, and I mean, I do it right in front of them. Okay, let me say that better. They go to the bathroom, pee in a cup, they bring it back, and I do the dipstick stuff right in front of them so they can see what all this looks like. Okay, most patients don't get to experience that, right? They don't really get to see the lab process, but that one's really easy, and we just do it right in front of them and fill out the appropriate chart for the records. Okay, so you can do a UA. You can also do another thing called Murphy's Punch. Okay, so what you do is you place your hand over the kidney and you strike your hand with your other fist, right? So let's say you've got your left hand on the patient's kidney. It's an open palm, open hand. You just simply place your hand on their kidney and you gently strike your hand. Okay, the hand that's actually palpating or touching the patient, you're striking your hand because you're trying to provoke the kidney on purpose. You're giving it a little tap, a little hit. You don't have to kill it. You're not trying to knock them out, knock their breath out, do a rabbit punch or a kidney. You're not trying to do that. It's just a gentle tap. And if the kidney is inflamed, it hurts more and increases the symptoms that they have. Okay, that's called Murphy's Punch. Okay, fancier things would be MRI. So imaging, MRI, ultrasound. Or X-ray. Okay, the better one is the MRI. And then the next best one for kidney is ultrasound. And then the third would be X-ray. Okay, what is likely causing the kidney pain? Okay, so it might be things like trauma, increased fluid accumulation, okay, infection, tumor, kidney stones, a cyst, okay, which is pockets of fluid that accumulate in the kidney, so cysts, bleeding, trauma. Okay, so just a few things to take into consideration with kidney pain, flank pain. And this is where your testing and your imaging studies and your exams and all that stuff rules things in and rules things out. Okay, other things that can cause kidney issues would be congenital. Okay, so that would be just malformations. And there's all sorts of varieties of different malformations. Okay. On a side note, your body can function with just one kidney. Okay. And if you do have one kidney, you've got to be very careful. Usually NSAIDs is now a contraindication. Okay, usually NSAIDs at this point is a contraindication. All right, so they would likely have to take Tylenol. Right, Tylenol goes after the liver, NSAIDs go after the kidney. So it just depends on which one you want to hurt for the day. Okay, and you'll have these people. People will come in because of over-the-counter drug overdose. Either the liver is going to be wrecked or the kidney, or both. All right. So the next one, let's do one more. Okay, I want to do a couple kidney cancers and we'll take a break. Okay, so we can have a renal cell, carcinoma, or a Wilms tumor. Okay, so the renal cell carcinoma is abnormal growth of the epithelial tissue inside the kidney. Okay, and it can either be genetic or lifestyle induced, such as drugs, alcohol. And by the way, this is abuse of drugs, abuse of alcohol, smoking, obesity, hypertension. Okay, poor diet. Okay, and then a Wilms tumor. This is typically a tumor found in kids. So your kidney cancer. Okay, so a pediatric type cancer. All right, it is considered a nephroblastoma. Now I spread the word out on purpose so you can see that this is kidney, and these are abnormal like cell proliferation. So your nephroblastomas. Okay, so the signs and symptoms for this the kid will have abdominal pain, and hypertension. You also might find hematuria, which is blood in the urine. Okay, and then treatment would be to remove the kidney, so a nephroectomy. And then chemo and radiation. Okay. Let's go ahead and break for lunch. We'll come back at 1 o'clock and we'll finish up. I'm going to cover some other kidney infections and kidney obstructions. Okay. And then just some other kidney diseases. All right. Okay. Let me see here. All right. Any questions or anything before we break? Okay. If you all could, before you log off or whatever, send me a chat that says here. All right. Awesome. Okay. I'll see you all at 1 o'clock. Okay, you guys could take a minute to download the PowerPoints. I'm going to go over 27, 28, and 29. Okay, give me a sec to screen share here. Okay. All right, chapter 27, intrarenal disorders. Okay, so these do primarily occur within the kidney. Okay. There are different things that can cause inside the kidney problems, such as congenital, neoplastic, which would be new tissue growth, infections, something obstructing it, or glomerular. Okay, so an example of congenital would be an underdeveloped kidney. Okay, so there you're seeing the kidney, and there's the ureter, and then the urinary bladder. Okay, neoplasms or new growth of tissue. Okay, and there are different stages. Okay, from stage 1 to stage 4. Okay, and it does depend on the location, depends on the stage. Okay, so stage 2 tends to be the greatest in dimension. All right, when cancer arises, you do risk it metastasizing. Okay, so metastatic disease. Okay, usually treatments for these would be to remove the kidney and then do radiation, immunotherapy, and chemo. Okay, with kidney infections, okay, keep in mind that the kidney does offer some protection. Okay, offer some protection to you. Urine is acidic, which means it is hostile to bacteria, and urinating or micturition does help wash away microorganisms. Okay. But the kidney can also develop pyelonephritis, okay, which is a type of urinary tract infection, or it can cause a urinary tract infection, okay, of the, so since it's upper, it's going to be the renal tubules. Okay, the renal calyces and the renal pelvis. Okay, there's the pyelonephritis. So that would be this area. So that would be an upper urinary tract infection. Okay, pyelo means pelvis. Okay, so that's where it gets, so it's alluding to this area in the renal pelvis area. Okay, so the acute, okay, a common infection or a common agent to cause acute would be E. coli. Okay, other things that can cause acute risk factors would be pregnancy, poor hygiene, okay, dirty hands, diabetes, and just in general bacterial infections. Okay. Okay, for chronic, this is usually because of some form of chronic kidney disease. Okay, you get usually get chronic decreased urine flow. Okay, so chronic decreased urine flow. Also a history of years of infection. Okay, and the history of years of infection can lead to this chronic inflammation, which causes scarring, and the scarring causes loss of function of the nephrons. So the nephrons start to just get burnout and hurt and destroyed over time. Okay, signs and symptoms would be painful urination, they can have a fever, okay, stomach pain, so low back pain, stomach pain, abdominal pain, Okay, with obstruction of the kidney, this is anything that interferes with the flow of urine. Anything that would interfere with the flow of urine. Okay, and that's anywhere from the renal pelvis, okay, anywhere from the renal pelvis area down to the urethra. Okay, so any condition that will slow down or stop urine flow. And in this picture, you're seeing a kidney stone that's pretty much blocking flow of urine from point A to point B there, okay, from the renal pelvis down the ureter. Okay, you can also see stones up here in the calyces, which would inhibit flow in that area. Okay, so prolonged obstruction can cause kidney damage. Okay, and it can lead to acute tubular necrosis. Okay, the fancy word for a kidney stone is caliculi. Okay, you also might see or read lithiasis, okay, because a lith is a stone. Okay, you also may read lithiasis, okay, nephro alluding to kidney. All right, some reasons. Okay, some causes can be genetic. Okay, genetic predisposition. Kidney abnormalities. Okay, dehydration. Okay, hypertension. And then usual suspects here, diet and lifestyle. Okay, such as drug intake, smoking, and any fluid that, you know, a person shouldn't really be drinking, okay? Because the kidneys have to filter that stuff out. Okay. So to diagnose, you can do an intravenous pilogram. Okay, an intravenous pilogram. So they inject a bunch of dye into the area and then take an image of it. Okay, you can do a CT. You can do a UA, okay, urine analysis, looking for stones and casts and, you know, epithelial tissue and whatever. Okay, for stones, for kidney stones, typically if it's less than 5 millimeters, it will pass. Okay, 5 to 7 millimeter size stone, it's 50-50 if it passes or not. And then greater than 7 millimeter is usually surgery. Okay, the stone is usually calcium oxalate. Okay, and these come from a saturation of solutes. Okay, so you get a saturation of solutes, and they start to form. So these crystals start to form because they're concentrating. So here's all your solutes, right? And then they get concentrated, and then they start to form a stone. Okay. And these are also very painful to pass. Okay, you've heard anywhere from it's more painful than childbirth to, simply the most painful thing you've ever experienced in your life. Okay, so these can be pretty painful. Because when you look at the calcium oxalate under a microscope, they're actually jagged. Okay, so crystals form very jaggedly. So and they nick and spur as they pass all the way down the tubes, right? The urethra, the ureter. All right. Okay, I want to do a couple other things with you. Okay, you can have okay, so glomerulus capillary circulation problems. Okay, so there's something blocking the glomerulus, right? So going back to our glomerulus with a knot of capillaries, proximal convoluted tubule, loop of Henle, distal convoluted tubule. And what happens is, because of the blockage, okay, you're going to get inflammation. And then that inflammation sends out a signal to bring in your Pac-Mans, such as macrophages. Okay. And these different Pac-Mans start to actually attack the glomerulus. Okay. So when this happens, this is called Berger disease. Okay, it's a form of glomerulonephritis. Okay, so inflammation of the glomerulus and the nephron, right? So that would be the glomerulus, Bowman's capsule, proximal convoluted tubule, loop of Henle, distal convoluted tubule. So all that gets inflamed. Okay, and so some side effects of this would be, so let's say additional cause or side effects. Okay, would be hypertension. Edema. Okay, so you start to swell because fluid is not getting through the kidneys very well. And you can also find blood in the urine. okay, which is called hematuria. Okay, another one with glomerulonephritis. Okay, is a condition called good pasture syndrome. Okay, this is considered autoimmune. Okay, so you get the glomerulonephritis. All right, so we'll just call that glomerulonephritis. And you're also going to get pulmonary alveolar bleeding. Okay, so pulmonary alveolar bleeding because of the antibodies. Okay, because you're going to also get these Okay, so unfortunately, these versions of antibodies attacks healthy tissue. All right. And then one more here, nephrotic syndrome. Okay, this is an increase in protein loss. Okay, so we call this proteinuria. Okay, so increased proteins found in the urine. So the kidneys are getting rid of too much protein. Okay, so normally when you have a kidney and protein is passing through, it's usually recycled. Okay, you typically don't want protein to go ahead and pass. All right, so that's not good if protein passes. In this case, it passes excessively. So you get a decrease in albumin. Okay, and when that happens, you get a decrease in pressure. Okay, osmotic pressure. And you get a decrease in volume, which activates the RAAS, so the renin-angiotensin-aldosterone mechanism, okay, which leads to sodium and retention. Okay. So treatment would be corticosteroids. And you can also do your RAAS blockers, okay, for nephrotic syndrome. but you really don't want people losing a lot of protein through the urine. Okay, that's going to take a bad situation quick. All right, let's do chapter 28. Okay, acute kidney injury and chronic kidney disease. Okay, acute kidney injury will typically be written as an AKI. Okay, it is also known as acute renal failure. Okay, so these two are basically AKAs of each other. So acute renal failure and acute kidney injury. Okay, so it can be sudden or acute. And you're going to get almost an instant disruption in fluid and electrolytes and acid-base balances. All right, you're going to start to keep the nitrogen, which will increase your blood urea nitrogen values. You're going to keep the creatinine, which comes from your muscle breakdown. Okay, so you don't want the creatinine, the breakdown of that to stay in you, right? You want your body to be able to get rid of it. And you'll find that there's a decrease in glomerular filtration rate. So going back to the kidney, right? The glomerulus is on the inside. As fluid is coming in, it should pass through the glomerulus nicely, but it slows down, okay? It slows down, which means you're going to get backup of fluid, okay? Because the pump, which is trying to push through fluid through the kidneys, well, the kidneys is basically blocking that. So you're going to have decreased filtration rate. All right, remember the kidney keeps the good stuff, gets rid of the bad stuff. Well, if you decrease the GFR, you're keeping all the bad stuff. Okay, so this is not good. And this can lead to end-stage kidney disease very quickly. Okay. Well, let me go back to this one. I want to talk about some causes. Okay, why this might happen. Could be trauma. Okay, obesity. Okay, drug use. Hypertension. Cancer. And diabetes. Okay, not an exhaustive list, but these are some of the things that can cause or lead to an AKI. All right, so we have three types of AKIs. Okay, they are pre-renal, post-renal, and intra-renal. Okay, intrinsic or intra-renal. Okay, the pre-renal is basically things that happen before the kidney. Okay, so you can see here, it is happening before the kidney. So heart failure, shock would be examples. Post-renal, okay, which means after the kidney. Okay, as you can see there, it's happening after the kidney. All right, so an enlarged prostate can cause this. Stones, so kidney stones, and obstructed catheter. Okay, and an obstructed catheter. And then you have intra-renal, okay, which means inside. As you can see, this is trying to show you it's something going on inside the kidney. And it's usually a damaged or hurt glomerulus. Okay, so the tubes in the kidney are blocked. Okay, and when this happens, it's called acute tubular necrosis. Okay, acute tubular necrosis. Okay, so if things are blocked, you're going to decrease urine output, which is called oliguria. Okay, so decrease urine output. All right. So chronic kidney disease can be from a loss of the nephrons, okay, the loss of the functions of the nephrons. And by definition, this would be greater than 75% total loss of the nephrons, okay? So if you lose 10%, okay, you lose 50%, okay, but once you start getting up to 75% loss, now we're getting into some irreversible damage, okay? And then what happens is typically a person has to have this for 3 months or longer. Okay, and once they have the 75% loss of nephrons and they've had it at least 3 months, then they get put into the CKD, which is chronic kidney disease, and there are 5 stages. Okay, so it's stage 1 through 5. All right, 5 is the worst, and 5 is also means you are on dialysis. Okay, and then by this time, you're considered in end stage renal disease. Okay, you're considered an end stage renal disease. Okay, so some complications of CKD. Okay, you're going to get sodium retention. Too much potassium in the body. You're going to become acidic. Okay, and then you're going to have to monitor, and they're going to have to watch out for hypertension. Okay, so diet and lifestyle will have to come into play. So they're going to have to watch how much sodium they consume. They're going to have to avoid your NSAIDs. Okay, they may have to take some sort of bicarbonate. And because of fluid and electrolyte imbalance, they'll have to likely do something with good fluids and good electrolytes. Okay, and then hold on, I want to make a comment on dialysis real quick. Okay, so in dialysis, okay, you basically have hemo dialysis, which means you're going into a clinic, okay, and they hook you up to a machine and blood comes out of basically one arm, goes into the machine, it purifies the blood and puts it back in you. Okay, so that would be hemodialysis. The other form is peritoneal. Dialysis. Okay, and this can be done at home. Okay, so what happens is in the person, let's see if we can draw a person here. Okay, so there's the leg, there's the bum, and here is the peritoneal cavity. Okay, so the peritoneal cavity has the liver and the intestines. So for now, we'll just say large intestine. Okay, you get the idea. So that's the area where those organs are found. And so all of this space, that is the peritoneal cavity. Okay, then they take, there's a dialysis bag, and there's a catheter that is inside the person. So it's surgically put into the peritoneal area. And the bag, which is filled with water, electrolytes, and salts. Okay, so it's a dialysis solution called dialysate. Okay, so the patient, they hook themselves up. Okay, so the fluid goes in, And then you have another tube that brings it out. Okay, and that's the outflow. And that goes into a bag and then disposed of. I mean, they'll still, sometimes they want to test it to see what's in there, but overall, that is, you're getting rid of that. Okay, so that would be a peritoneal dialysis. Okay, next one is 29. Okay, disorders of the lower urinary tract. Okay, so we'll be focusing more on the actual urinary bladder. Okay, so this would include the ureter, the urinary bladder. Okay, so all that, the urinary bladder, the urethra, okay, and the urinary sphincters. Okay, the fancy word for urination would be micturating or voiding. Okay, so for lower urinary tract disorders, they can include things like voiding dysfunctions, can be congenital, so just didn't form right, neoplastic, infections, inflammatory, or obstructive. Okay, so incontinence is the inability to control the urine. Okay, so you can be a bedwetter. Okay, which is enuresis. Okay, so enuresis is a form of incontinence, and that specifically is a bedwetter or incontinence while sleeping. Okay, it can also happen because of cancer. Okay, incontinence because of cancer. Pregnancy. Okay, could be neuro. So your sympathetic nervous system versus parasympathetic nervous system. A form of dysautonomia. Okay, so dysautonomia is where the automatic nervous system, right, your involuntary nervous system, which controls a lot of the urinary bladder function, kind of goes haywire. Something's wrong neurologically. Okay, the urinary bladder, the okay, the detrusor muscle in the actual urinary bladder is under involuntary or autonomic control. Okay, and the conscious control is on the external urethral sphincter. Okay, this is a voluntary control. Okay, so there could be something wrong with these systems, and things to consider, other things to consider could be abuse. Okay, psychological issues. Multiple sclerosis. Okay, Parkinson's disease. Okay, the urethral, the external urethral sphincter is also innervated by the pudendal nerve. Okay, so the pudendal nerve runs in that perineal area. So if you can visualize yourself sitting on a bicycle seat, okay, visualize sitting on a bicycle seat, where that saddle would be touching your body there, the perineal area, that's basically where the pudendal nerve innervates. So what can happen is you can receive trauma to that perineal area. For example, some people are riding a bike and they're sitting on a saddle that doesn't fit them properly, and all of the saddle pressure is pressing on the pudendal nerve. Okay, decreasing nerve function. Okay, that's one reason why when you look at bikes, especially good saddles on a bike, there's a groove down the middle of the saddle on purpose to try to take pressure off that pudendal nerve. Okay, people that sit for too long, you know, just day after day and all that stuff, year after year, just that gradual subtle pressure on the pudendal nerve can decrease its function. And of course, trauma can do it. Okay, so in other words, neurological. Okay, so congenitally, there are just some, you know, the way the tubes, the valves and the tubes were formed. There's not a complete seal, so to speak. So you're constantly getting leaking. Okay, also cysts. Okay, so you can develop a kidney stone or a cyst, and the inflammation can cause things. So there's the tube. It can cause it to swell. So it went from that big to now that big. Okay, and so it can't retain fluid very well because of the inflammation. So you get dilation of the ureter. Okay, cancer. Okay, fourth most common cancer in males, ninth most in females. Increased risk as you get older. Okay, so the tumors, as they enlarge, can start to affect the integrity of the lining of the bladder, okay, which is under involuntary control. And so it loses its muscle function. Okay, it's a type of smooth muscle. So it does lose its function, which can lead to some problems. Okay, another one is urethritis, so inflammation of the urethra. Okay, usually caused by an STD, some form of bacteria, poor hygiene, okay, frequent catheterization, okay, and then signs and symptoms would be pain upon trying to void or micturate. Okay,